So I make it noon. Just want to say thank you to everybody for turning up. I hope you managed to get some lunch. Good news that there are very few chairs available, but there are very few chairs available. So if you can clear the ones that are free, there are people who are at the back of the room, all filling in here. So I just want to introduce myself. I'm moderating this session. I'm Monty Mython. Up until relatively recently, I was working for the critical care component of Edwards Lifesciences. Just prior to that, I was the chair of anaesthesia and critical care at University College London in the UK. And most recently, myself along with my colleagues have transferred to Becton Dickinson we're now called BD Advanced Patient Monitoring. So that was an acquisition that took place, and we're delighted to be joining that company, which brings great synergies. So this is a sponsored lunchtime session. So if that wasn't clear to you and you're not comfortable in the room, please put your sandwich back down, and now's the time to leave. It's great to see you. And I'm sorry that it's great that it's so busy, but I'm sorry that so many people are needing to stand. So I'm just going to ask our other guests to introduce themselves, starting with Dr. Guerrero Londono.
Nice to meet you, everybody, and thank you for this invitation. I'm the medical co-director for the Division of Research at Henry Ford Health in Detroit, Michigan. I'm an anesthesiologist and a cancer anesthesiologist for fellowship.
And Dr. Meng?
Hi, good afternoon. My name is Marie-Louise Meng. I'm a cardiothoracic anesthesiologist and an obstetric anesthesiologist, and I work at Duke and help our MFMs out with our pregnancy heart team.
And Dr. Davis?
Thanks, Bonnie. My name is Simon Davis. I'm an anaesthetist, not an anesthesiologist, so I'm from the UK, and I'm half NHS, so major abdo surgery and vascular, and half my time is spent at university in academia.
So we're shuffling our microphones around here a little bit. I hope you can hear us okay. Can you hear us all right at the back, Patrick? That's great. Thank you. So some disclosures to share with you. So I am the Senior Vice President of Medical Affairs now for Advanced Patient Monitoring, a division of Becton Dickinson, recently acquired from Edwards Lifesciences, as I touched on at the beginning. And all the other speakers are paid consultants. The views expressed herein are those of the speakers. The session does not provide CME or CE credit. There's a longer disclaimer here that we're asked to put in. And in it, you can see a link, which is the edwards.com/EIFU, which highlights the fact that we're going to discuss very many different clinical areas in this case, in the presentation we're about to have. So if you want to check about the monitoring in those contexts, please do follow up with the link that's there. So intraoperative hypotension, I think possibly we're getting a bit bored now of hearing about the fact that it's very common and it's associated with significant patient harm. But let's touch on this example for a moment, if we may, Simon. Published by Andy Shaw et al., Gregory first author, looking at many patients in the USA and many hundreds of centers. And what you see on the graph there, as the dots go out to the right-hand side, it's an increased odds ratio for each 5 millimeters of mercury of change in blood pressure for having a serious harm. And there are 3 thresholds of blood pressure, 75, 65, and 55, that being a mean arterial pressure. So what do you think, Simon?
I think you're right, Monty. I think we all know that hypertension is harmful. I just don't think we realised how ubiquitous it was. It's not just our high-risk elderly patients. We see that trend to harm in males and females, in high-risk, intermediate-risk surgery. We see it across all age groups, so not just the elderly. The risks were just as high in the 20s if you look at the material in the supplemental sections. And we also see that harm is associated with different thresholds as well. Now, we've settled on 65 or thereabouts, but there is also harm at different thresholds too. And more importantly, it's not just AKI mins. It's all sorts of sequelae from hypertension. It can be surgical site infection, it can be nausea and vomiting, it can be mortality, it can be mins.
And we keep reminding ourselves these are associations, not necessarily causation, but I think there's growing evidence that we can address the causation issue. But the title of this talk was very deliberately that hypotension is not a number. It's a pathophysiological state. So you as an individual might be hypotensive with a number that's significantly above 65. It's about whether there is evidence of underperfusion of tissues at a particular threshold of pressure. Let me ask our other two. Do you want to start first, Carlos, to comment on that?
Yeah, I think that this is something that we commonly see, and right now there's some multi-center metrics that also are targeting us reducing hypotension. So kind of like stressing how agreeable this goal is for practice.
You can grab the mic off.
Sure. And I like thinking about this hypotension as a real kind of threshold that may be changing with obesity epidemic, higher rates of chronic hypertension, and all of these diseases moving into younger populations. So on the labor floor, we see way more women with hypertensive disorders of pregnancy, and that MAP threshold is actually a lot higher than what we've traditionally used because of how sick our patients have become.
So customization of the blood pressure. And as you say, you see it in very many different forms and very many different guises. This example, Simon, I think talks to post-operative nausea and vomiting. So sometimes you can see the consequences immediately. And certainly in obstetrics, you see it very immediately, that we'll come to in a moment.
Yeah, with some of the studies that we read, we don't really, doesn't gel with our practice. We don't see AKI because we don't see the patients after they leave the post-operative recovery room. We don't see the systemic inflammatory resection because they're on the ward later. But actually, we can see the consequence of hypotension immediately after surgery. If we make them hypotensive or allow hypertension to occur, we see things that we don't want to see. They're sick, they're shivering, they're vomiting. And that's, when you ask patients what's important to them, the two things they constantly say are pain and sickness. Those are the things they're most concerned about around about the time of surgery.
And in OB practice, with the use of epidurals or spinals, for example, you see it very immediately, don't you? It's a long time since I've done it, but it was a scary moment when they went pale just before they emptied onto you.
Yeah, I mean, a C-section is the most commonly performed surgery in the world. And the first thing we do is we initiate neuroaxial anesthesia, and we know that there's going to be hypotension from that. If your block is at the appropriate level, your blood pressures come down. And so we have to be treating this, but then you're going to have a blood loss. So there's lots of different things happening and many reasons for the hypotension, but it's the same kind of pathway for every single C-section. And having a team that stays on top of that creates a more comfortable experience for the awake patient celebrating a birthday party.
And it's good for the baby to come as well, isn't it?
Yeah.
We hope. So we're not going to linger too much more on this. There's just masses of literature now reinforcing this point of the association with harm. One sadness, perhaps, is it doesn't seem to be changing much over time. We just seem to keep telling each other there's a lot of it and it's not good for you. Simon?
It's not changed, you're right. We go back to Jan Bicker's thesis in 2007, about a third of patients were hypertensive. We jumped forward to the Cleveland Clinic work, the same metrics, and recent work you've done just last year shows exactly the same instance of hypertension. It's not changed for 2-3 decades, and we have to ask ourselves, why hasn't it changed?
And we'll come back to that paper on the right-hand side there as you look at it, presented relatively recently in Perioperative Medicine, 2 large anesthesia groups in the USA collaborating to look at hundreds of thousands of cases and hundreds of providers, finding that about 30% of the cases had a low blood pressure below 65 millimeters of mercury cumulatively for more than a quarter of an hour. So it's a lot of hypotension. Now, while SASU, and I'll come back to their papers at the end, will be presenting some work at this meeting tomorrow, the articles are actually picked up so quickly, they've already been published in the journal Spine, but we'll show some data at the end where they've intervened and they've made that problem pretty much go away, and a lot of the problems have gone away with the hypotension going away. And you'll share some data with us as well shortly, so that's great, thank you. So in conclusion, Simon, what do the latest guidelines say? Same old, same old?
Same old. Keep the blood pressure above 65, and we see guidance from both POCI and from Medicare papers as well. But we've got some more refined guidance coming on a bit later on about not just treating a number, but treating the appropriate underlying cause as well. But we'll see why that's important.
Right stuff. Anything, everyone happy with that? Move on from that at the moment? It's there, it's common. Right, you can't treat what you don't measure. So thank you, Patrick, for that slide. A small round of applause there for that. Simon, what's this all about?
Well, it's hear no evil, see no evil, treat no evil. If you don't measure it, you can't treat it. And we're still reliant today on oscillometric telemetry. Victorian technology, we've come along since then. But if you use intermittent technology, you measure the blood pressure every 3 minutes, 5 minutes, and you miss episodes of hypertension. So the graph you see on the right-hand side is a fractured neck of femur patient. They have a finger cuff on for continuous measurement, but the clinician is blinded to that. They're just using the arm cuff. And you can see that the mean arterial pressure dips below the threshold of 65. It's recognized, then it's treated. A few minutes later, it's dropped down again, but we're accumulating hypotension over the course of the operation.
and we'll come to our other guests in a moment to comment on this, but jump forward to some of the body of evidence that exists now, making comparisons of continuous measurement, whether you use an arterial line or the finger cuff technology, compared to intermittent oscillometric arm cuff.
So randomized controlled trial, you're split into two groups. Either you have a continuous monitor, that was the clear site, or you're monitored continuously, but the clinician is blinded to it. And that's our intermittent group. And we can see that both during induction of anesthesia, where a lot of hypotension occurs, about a third of the burden happens around about that time, and during surgery as well, we see a reduction in the amount of hypertension, around about 60 and then 90% reduction in the amount of hypertension. But the interesting thing for me is that variation. Look at the variation in the intermittent group. Some people are accumulating huge amounts of hypertension by not having it measured continuously.
So we'll just orientate people a little bit more here for a second. It's the red dots are continuous, the blue dots are intermittent.
Yep.
The first bars are area under a map of 65, then it's 60, then it's 50, then the right-hand one is 40. So there is some hypotension happening below 40. The left-hand cluster of graphs is induction. The right-hand ones are during surgery, and basically a massive reduction in the study by just having continuous measurement available.
Which is common sense.
Yeah.
If you can see the number, you can treat it.
Well, let's determine if it is common sense. Do you think?
Yeah, I mean, we're all moving towards continuous monitoring and all spheres of our practice. The more we have data, the more we can act on it.
Yeah, and I think what you see here is that it's going to really affect some patients more than other patients. So it's going to be not just outliers, but it's a pretty big group of outliers that you're going to save if you're able to recognize it earlier.
So you've been involved in publishing this. Make a great T-shirt, I think. Actually, what's that all about, Simon?
This is of the 80s and a bit of tie-dye. We know that hypertension is harmful, and we are potentially, as we'll see in a bit, causing a problem by treating it blindly. And it's just to really remind people there are different endotypes, so biological profiles of hypertension. So this is from around about 2,000 patients undergoing major abdo surgery. We've taken the data of stroke volume, of mean arterial pressure, of heart rate, and we put it into a machine learning model. So it's called the autoencoder. And what it does, it groups data together that looks similar. When it comes out the other side of this sort of unsupervised learning, what we see is we can identify 4 distinct types of the cause of hypertension. And the things we recognize, it's preload, afterload contractility, so hypovolemia, myocardial depression, vasodilatation, but also there was a bradycardia cause to hypertension as well, what we haven't really realized in the past. And the mean heart rate in that bradycardia group was around about 58, so not bradycardia as we sort of think about it in day-to-day practice. But just emphasizing, we can identify 4 different types, and it's important to treat the appropriate cause.
So it used to be when I was a young anesthesiologist that you'd start with a bit of fluid. And if that didn't work, you'd probably reach for your ephedrine before you reached for your phenylephrine, because you wanted a bit of beta rather than pure alpha, because a lot of the hearts weren't very good. And then if that was becoming irritating, and they weren't bradycardic, because then sometimes that would be an issue, then you'd go for the phenylephrine. But now it seems to be that phenylephrine is the answer to all hypotension. Is that being a bit too harsh?
Oh, it's the answer to treating a number. It may not be the answer to providing better outcomes.
Have you seen this in practice? Have you seen phenylephrine being the universal panacea?
I mean, it's been consistently used, and it's been, again, when we push ourselves to look at a number or maybe measure by a metric on whether we were below or above that number, then there could be a reflex action of, I know that there's a medication that, regardless of the cause, will fix that number. And sometimes that could be dangerous if we don't pay attention to what the mechanism or the cause of the hypertension is.
So, Simon, I'll just tee you up for this one. This is the Multi-Centre Perioperative Outcomes Group. It's published in the British Journal of Anaesthesia. So it's a group of centres collaborating in the United States of America to look over a 5-year period. You can see the graphs there are 2015, 16, 17, 18, 19, looking at about 20,000 patients, and they're demonstrating fairly clearly that the amount of vasopressor expressed as total norepinephrine equivalents has gone up, as has the total phenylephrine and total norepinephrine per se, which makes up the adjusted variable. At the same time, the amount of fluid has gone down, and the bottom left-hand corner, as you look at it, shows the number of, in crystalloid equivalents, the mils per kilo per hour, with an inflection point of 10 mils per kilo per hour, which we used to think was a modest amount of fluid, but now somehow has become a sort of excessive amount of fluid, that for each mil below that, the risk of getting AKI goes up. And as I recall, over the time period of the 5 years, there was less intraoperative hypotension, but there was a little bit more acute kidney injury. So you're robbing Peter to pay Paul. And we seem to hear about, there's numerous reports of this now, we seem to hear about this everywhere as being a sort of new global pandemic. Simon, we'll go back now.
I think you're right, Monty. And what we've done is caused ourselves a problem by trying to solve a problem. So we are treating the number, we're treating it blindly. And this, I think, sadly reflects my practice to some degree, in that I often now start and feel effort of inductive anesthesia to avoid that hypotension. And that's fine because you're defending blood pressure. But what you have to then think is, what's the true underlying cause? So not just keep that vasopressor increasing and increasing throughout surgery, but once you've got through that initial instability reduction, think, well, what is the underlying physiology that might be causing potential hypertension?
It's entirely logical to use that vasoconstrictor around that period of induction of anesthesia, but then it would be, we used to turn it down or off then to see what happened next, but it seems as though it's sort of creeping up. Now, OB's different in many ways because C-section, for example, you're hoping it's over pretty darn quickly. So maybe defending pressure is fine in that situation.
Yeah, and sometimes it's not over very quickly, and
Okay.
we run into hemorrhages. And so understanding whether it's still your neuraxial that's causing the hypotension or a hemorrhage that you're aware of or not aware of. So that's a bit more of a dynamic procedure.
Yeah, and in my practice with cancer patients, we often run into very long surgeries, and it's a game of time. We can't be too aggressive at the beginning, but we also have to consider what happens over and over and over, communicating. And it doesn't, looking at the causes is a reinforcement of our clinical judgment. It doesn't, the fact that we can have alerts and systems to help us does not replace the fact that we also have to do our due diligence to judge.
We're going to switch to the gut for a second. Why, Simon?
Because it's not just not just the kidneys that suffer. And we think about the commonest post-operative complication that we see, regardless of surgery type. It's actually nausea and vomiting and GI dysfunction. So whether you're having your knee replaced, whether you're having a colonic surgery, whether you're having ophthalmic surgery, post-op nausea and vomiting is the commonest complication we see, and patients dislike it. And that's because the gut is very, very sensitive to volume loads.
So on the left-hand side here is an electron micrograph taken for a microbiopsy of the GI tract. In the last century, some work I was doing with I love saying it that way. In the last century, some work I was doing with my colleagues back in London. On the right-hand side is a cartoon of the structure of the microvillus. So beautifully designed for the absorption exchange of nutrients and water, but susceptible to hypoperfusion because it has a countercurrent blood supply. So there's an arteriole running along the bottom, then an arteriole runs up the middle of the microvillus, and then wrapped around that side is the venous vessels on the outside. And with any countercurrent system, once you get a reduction in flow at the bottom of the vessel, the oxygen will tend to jump across further down the microvillus from the A to the B side. So you can see even in health, this is in millimeters of mercury, forgive us for those who work in kilopascals, that the arterial tension of oxygen is 100 millimeters of mercury at the base of the microvillus. It's 40 at the tip in you sitting here at the moment, which means that the tip of the microvilli are exquisitely sensitive. They're just they're undergoing programmed cell death that can switch very easily to necrosis. And that manifests itself in us, air travel, exercises, runny tummy, for example, or feeling a bit nauseated, fully recoverable. But if it goes on for too long, it can become a major problem. Post-operative nausea and vomiting, translocation of bugs into the bloodstream that can seed deep-seated infections, ileus.
And that's why it gives some of the biological plausibility of why hypertension leads to things such as wound infection, because you do get translocation of bacteria, particularly enteric ones, through that gut membrane once it starts to be disrupted.
And the other thing we must remind ourselves is if you get hypovolemia, any hypovolemia at all, which we'll demonstrate to you in a second, you squeeze the blood out of your splanchnic organs preferentially. You sacrifice the spleen first, followed by the gut mucosa, followed by the serosa, etc. You squeeze the blood supply out to maintain a central heart, lung, brain circulation. That's a survival tactic. So we'll bring everyone else back in a second. What's going on here then, Simon? This is from one of the studies that we were involved with and others in the room.
What we're doing here, or what we're trying to show, is that if you look at all the numbers on the right-hand side now, we've got a good cardiac output, we've got a good stroke volume, maybe slightly high, stroke volume variation is reasonable. If you walked into an operating room and you saw that, you probably think, good job. Okay. SVV was a bit raised, so SVV is our preload response parameter. At the start of that time frame there, it looks like we've given some fluid. Our stroke volume variations come down, and our stroke volume and cardiac output have come up, and we've got a good map. So it looks like happy days.
Happy days. Agreed?
Yeah.
Looks okay. Agreed?
Though I'd be a little curious why the cardiac output was a bit high and the stroke volume was a little high.
Uh-huh. But overall, a pass mark?
I think most people would pass and not think too deep about that.
True. Well, what was going on, Simon?
So actually what that was one of the porcine models that we were doing. And so that porcine model has been hemorrhaged relatively severely. And what we've done is started a vasopressor to make all the numbers look good. And so as Monty was saying, what we've done is squeezed our splanchnic circulation. We've got a bit of free blood in our spleen. That's okay. That can go into our central circulation. But after that, our splanchnic circulation starts to become compromised, and we affect the gut. So what we can see there is a real-time image of the pictorial that Monty was describing. So we're doing side stream dark field microscopy. So made a small incision into the abdomen, brought out liquid bowel, and we can place that directly on it. And that is a healthy microcirculation. Those thumb-like structures are your villi, and the things wishing around there are your red cells. And in health, microcirculation flow is constant. It's not pulsatile or precapillary sphincter. It's regulated, so we have a constant flow of blood around our villi there. And that's a normal, healthy one on the left-hand side. Monty, looking at the one on the right-hand side with a hemorrhage and vasopressor?
Well, you need to look closely within the microvilli. So the walls of the microvilli are now starting to swell, and within the microvilli, there is no flow in almost every microvillus. What appears to be flowing is the slurry on the red cell hemorrhaging from the necrotic cells around the microvilli. Now, again, back in the last century, when we were doing simpler, more basic science, when we would biopsy guts in this state, and we'd measure, for example, the amount of serotonin that's pouring out, we would find there's massive amounts of serotonin. Then scientists in drug development would radio label that serotonin, and they would track it up the vagus nerve into the vomiting center in the brain. And it was that piece of observation that led to the development of 5-HT3 antagonists, ondansetron, for example, to say that the sickness, the retractable, horrible sickness comes from the gut. There are other reasons for it. But that biology published in the New England Journal of Medicine about ondansetron is beautiful. And that is post-operative nausea and vomiting in the making. That is ileus in the making, or ileus in the making.
But reversible.
But reversible,
Yeah,
fully potentially reversible.
We can see that in the lab. So we give that volume back, then that flow goes back to normal within a matter of minutes. But if you keep that vasopressor on and you don't think about the underlying cause or the physiology, have that for 2 or 3 hours, and as you say, you start to get membrane disruption, bacterial translocation, and that's when you start getting complications.
And as a result of that, you'll get GI tract dysfunction. It will take a couple of days to settle in. You'll get an ileus. You'll have that horrible POMV. You'll then start to get some lung breathing problems as you splint your diaphragm. Then you get a little bit of chest infection. Your venous blood's backing up to your kidneys. You're getting a bit of AKI. You get multiple organ dysfunction syndrome. If you're unlucky, you get multiple organ failure. Now, that doesn't happen to most patients. What happens to many patients is a bit of that, isn't it? So, making sense? Familiar? Okay, familiar?
Yeah.
Whoa, okay. So, latest guidelines emphasize, Simon, this is the Perioperative Quality Initiative, re-emphasizing the map of about 60, but they've added a couple of extra paras on the right-hand side there.
Yeah, this is this year's or last year's updated, and whilst the focus of the previous guidance was maintain that map 60 to 70, which still holds true, it's now saying that hypertension needs to be treated based on the underlying cause, not just treated blindly with a vasopressor. And also, because of the burden, the amount of hypertension that we see, which hasn't really changed over 2 decades, we really should think about having more continuous arterial pressure monitoring, be it either invasive or through the non-invasive cuff mechanisms.
I think that's Motherhood and apple pie. We're all happy with that, I think. And
Right.
the Anesthesia Patient Safety Foundation has expressed that in a slightly different way, but the same message.
Yeah, so both sides of the pond, the overall message and the tone is exactly the same. Don't let your patients be hypotensive, and when you treat it, think about the underlying cause.
Not just fixing a number. So it's a pathophysiological state for the individual. If they have evidence of hemodynamic instability, treat the driver of the hemodynamic instability, not a magic number.